So first of all, let me introduce myself. My name is Liam. I'm one of the advanced practitioners at the Royal Alex Children's Hospital. Background in paediatric and emergency medicine for 20 years. I've only been with the Alex team for just less than 2 years. I come from a department where we would have done ketamine sedation for limb manipulations beforehand. But what we're going to do today is we're going to really talk about what we do at the Alex. So obviously we know that everyone does different things. And I think, we can probably have a bit of discussion at the end about the pros and cons of the different ways that people may do things. I'll let Hannah introduce herself quickly.
Hi, I'm Hannah, paediatric EMP in Brighton. I've been doing it for about 2 or 3 years. I did an on-the-job training within the department, and I've been in the Children's A&E in Brighton since I qualified as a nurse about 20 years ago.
Okay, so we'll start the slides. Me and Hannah will probably share around the slides a bit more, as we go along and sort of interject with each other. But we'll just sort of start. Mainly the main aims, I think, obviously from the discussion we're having at the introduction to this session today was going to be more around manipulations, which we've got at the end. And we kind of structured our presentation just around what we do for any sort of forearm fracture in the department, first of all. So we can go through a little bit of that. So we'll talk about some of the more minor ones as well. As I say, we'll talk you through what our assessment is, our management. We'll have a little discussion and say at the end about the different management options, and we'll probably touch on sort of the current standards there are around and what sort of research has been undertaken to do with paediatric forearm fractures. Okay, so when a patient first comes into the ED, we want some initial principles in place, or some standards that should help. These children are coming in, they're a bit scared, they're a little bit nervous, they've had a nasty injury. So it's making sure that you've got obviously appropriate trained staff at triage who can identify these patients, see what kind of priority they are. So if it's a minor arm injury or something that needs a bit more immediate treatment. So are they able to pain score properly as well? And can they obviously get these children to have some adequate analgesia as they come through the door? Obviously, with any child weeks coming through, we obviously hope to have a parent, so we can keep them, to use for comfort where it's possible. Obviously, you may get the odd child, like the teenagers that may turn up without a parent on their own. They might be quite scared and nervous. So just trying to find someone to be with them is just as important. And obviously, if you're lucky enough in your department to have a play specialist, that would be great. We did have one. We're hopefully going to put up for a new one. But I've worked in places where there's a play specialist in place, and they're worth their weight in gold when it comes to helping with children that are in pain. And just making sure that you have some distraction techniques around. We'll talk about some of the stuff we've got a bit later on, like our 3D TV and our goggles. Put some good images a little bit later on how we use those. So when they come in, obviously, with any patient, you want to get a bit of history about what's happened, what time it happened, where it happened, was there any witnesses, was first aid given, have they had any pain relief before they've come to us? So you get a better idea of how the injury happened, and sometimes the severity of it, and making sure there's no other injury. They may come in with a wonky looking arm, but have they also been hit by a car to get that wonky looking arm? So there's other things you should be looking at first of all, or if they've fallen from quite high from a tree. Obviously, other things that we all should need to keep in the back of our mind is, is there any kind of non-accidental injury? And if, or if there's any, history that there may be an assault that's happened. So you may need to obviously consider your safeguarding review, or if you're lucky enough, again, like we are at the Alex, to have a youth worker, get their input into the situation as early as possible, because that can really help, especially if you've got a teenager that is quite frightened or scared and worried that they might be in danger, that you've got someone there that can help put them at rest, or put them at ease, not rest. Anything else that you want to add there, Hannah?
So we're lucky that we have the youth worker that works in our A&E department, so they will come and see like punch injuries and things like that, and chat to them whilst they're in the department, and just see if there's any way they can kind of help them.
So moving on to examination and assessment, obviously there's different ways of doing it. You've all probably been taught different ways how to assess an injury. I tend to use inspection, movement and palpation. I know some people use inspection, palpation, then movement, but whatever works for you. I just find that with children, they might just be a little bit more nervous if you start touching them first before getting them to move their limbs, and then they might be a bit more scared due to the pain that you just might have elicited at the time. So obviously, going back to inspection, you're looking to see if there's any swelling, deformity, what's the colour of the limb, are there any wounds, making sure is there any injuries, above or below the injury that you need to check out for, and then sort of move on to the movements. So, what movements can they do themselves? Will they allow you to move their limb for them? Is there any resistance to this? And make sure you document what they can do. And again, you're also checking for these movements, in the joints above and below the injury as well. When we come to palpation, we're obviously looking to see where there is bony tenderness, but obviously, if there's a big bend in the arm, you don't need to go touching that to know that's probably quite painful. You can probably look at the child and see that. Okay. We might touch on it a little bit, but we're not going to go into a big detailed look at scaphoid fractures. But obviously just be aware that from about the age of 9, you need to sort of start assessing for scaphoid fractures, because they are one of the things that sometimes get missed in pediatrics. So that's just something to be a little bit more aware of. So, in terms of examination, we also need to make sure that we're thinking about the neurovascular assessment of the children. So there's a couple of little methods you can do. There's the rock, paper, scissors method, or the Kumar sign, just to make sure that all the nerves are working. And obviously, if you want to check things like sensation, is a simple test is get them to close their eyes and ask them to move the finger that you touch, something like that. Make it a little bit of a game, especially the younger children respond a little bit more to that, because they're not always able to tell you, if they can feel anything at all by just asking. Okay, so obviously you've identified you've got a child that's got a probable fracture. So thinking about next steps, what analgesia you're going to give them. I've included a link here for the Don't Forget the Bubbles analgesia guideline. It also got a bit on procedural sedation as well, which you can have a look at. But obviously with a more severe injury, just thinking about the fact that you're probably going to have to work down the pain ladder. I know we usually talk to work up the pain ladder from paracetamol, ibuprofen, then up. But ideally, these children, you probably need to go in with some good strong pain relief to start with. Maybe that's some intranasal fentanyl or intranasal diamorphine if you got it. So just to get them as settled as possible. Next things is obviously a mobilization of the limb. So simple things like putting it in a sling, so taking the weight off it can help. If can you put a splint on it that'll hold it, or if you need to do a cast straight away. So for us, obviously ideally you'd like to get some imaging before you put any plaster of Paris on these fractures, because obviously it can shadow over some of the fracture joints. But unfortunately for us at the moment, our X-ray departments are a couple of floors away from us. So if you've got a child that's got quite a bendy arm, you want to put them in some kind of splint. So we'll either use some Dynacast or put a PAB, plaster of Paris back slab on for them to go down there to give them that added pain relief when they're going to have those done. Unfortunately, again, for us, out of hours, we have the other X-ray department there to go to the adult X-ray over by the adult A&E, because our children's ED is in a separate building from the adult ED. So there's a little bit of distance. So those sorts of things to think about, the geography of your hospital, if you're going to be sending them for imaging.
After putting a cast on, it's always really good to try and check the neurovascular status again, because it might be a bit, if it wasn't 100% beforehand, then once you put a cast on, it might be more pain, and once that's on, you might be able to get a more accurate neurovascular status.
Yeah. So we've got our own guideline, quite a few pages guideline at the Alex of what we do about fractures, and we've got some pretty good, we've got pediatric orthopedic consultants that support what we do. and help us out. Simple undisplaced fractures of distal forearm, a lot of them we can now get away with a wrist brace. So we'll mention a bit later on, but like a green stick fracture that's not there's not much sort of angulation, you might get away with putting a wrist brace on. Our pediatric orthopedic consultants are quite happy, would rather take a wrist brace off and put a plaster on than take a plaster off and put a wrist brace on, because obviously if the child has to have a plaster on then taken off, there's the bit of the fear with the plaster sore, or there's a parents, obviously if they've had the child in a plaster for a while, sometimes or the brace isn't as good as the plaster. But evidence is tending to show that wrist braces can be used in a lot of these fractures. Obviously, things if you worry about, you've got a bit more of an angulation in the fracture, you might want to put a backslab on for a little bit more security. Undisplaced simple fractures, mid-shaft forearm, we tend to put in a POP above elbow just to limit the elbow movements, again to reduce the pain. And obviously getting these children into some slings again where it's appropriate. Most of these simple ones we have a virtual fracture clinic. I assume from what I hear anecdotally, most hospitals in the country now are probably post-pandemic doing a lot more virtual fracture clinic follow-up. So obviously it saves patients having to trek all the way into the hospital for every appointment. And obviously it saves everyone sort of time and money, both for the trust and for the parents. So that's a good thing that's come out of the pandemic.
Simple buckle fractures, we see a lot of. We treat them in a splint for 3 weeks. There is the FORCE study that says you don't have to treat them in a splint anymore. So it just depends. We have the real small pediatric ones for the little patients. They quite like them, but we have issues sometimes with putting them on because their arms are too chubby for the size of the splint.
Yeah, so yeah, we've had a recent one where I've managed to, the child you can get a splint on the size, too chubby, explain to parents about the type of fracture it is, and would the child even keep the splint on even if we put it on, and even if we put a plaster cast on, it was going to probably be able to get that off pretty easily, like a back slab. So we talked about the risks and benefits of just leaving the child out of the cast and splint, and the parents are happy. And thankfully, it was also a work colleague who able so far fed back that everything is all okay. So the nice evidence search before they started the FORCE study kind of suggested that we might not need to use anything. But I know in most of the times, I think parents are quite happy to have a brace or a bandage. Feels like something's been done sometimes. Okay. Obviously, green stick fractures, which I touched on earlier on. Obviously, you still have one cortex usually intact. Again, we can either splint them, below with plaster of Paris. Depending on, again, these again can depend on the angulation. Other things can be the child's level of pain. Sometimes plaster has better pain relief than the Futura splint, and sometimes it can just be preference. Are the parents happy with a splint? They may not, if they're not particularly sure, don't seem reassured by what you're saying, then a plaster of Paris is just happy to go on as well. Okay.
The green stick fractures ones that we put into splints, we tend to tell them they can't take them off at all, whereas the buckle fracture ones that are in splints, we say they can take them for a bath or a shower, but the green sticks have to keep them on and keep the splints dry.
And again, as I mentioned earlier on with the mid-shaft green stick fractures, again, these can go into a above elbow plaster of Paris. I don't know. I know sometimes that you've got a little buckle in the cortexes, maybe at the radial head or something like that. You might get away with putting them just in a sling. But I think Anna will probably touch a bit more on that later on when she does her talk on the elbow fractures. So that'd be good to hear about. So we mentioned scaphoids as well. Obviously, most people are probably quite aware that it might not show on the first sort of images you have. Once you've assessed for it, so obviously make sure that when they're above 9 that you're assessing the anatomical snuff box, telescoping the bum to see if there's any pain being elicited over that scaphoid area. So if there is no sign of a fracture on the initial X-ray, we will probably put the child in a wrist brace. We'll arrange for a fracture clinic follow-up, and they probably have another X-ray done at 10 days time to see if any changes are showing. If there is evidence of a fracture, we tend to put them in just a below elbow back slab. Don't need anything fancy. Don't these fancy scaphoid casts or anything like that. I mean, if you're able to do them, great. But as far as we've been told by orthopedic teams, a back slab is adequate for these. Okay. So for the more complex ones, and we will talk about what we do at the Alex in a moment. There's obviously can these ones be manipulated in the children's ED? And a lot of teams are moving to that. Now, there's lots of different ways you can do it. We'll talk about our way at the Alex in a moment, which is the intranasal fentanyl and the nitrous oxide. There's obviously ketamine sedation. Just include a little link in there for the RKM ketamine procedural sedation guidelines, which you can have a look at if you haven't got them already. And there is the nitrous oxide 70-30 sedation, which I understand was previously used at the Alex, but at the moment, I think due to the amount of staff that we've got, is I haven't used it in the 2 years that I've been here. So I'll let Hannah talk a bit about that in a moment. But I am just a little bit of background. I say I came from another trust where we did the intranasal fentanyl, not intranasal, sorry, we did ketamine sedation. And from my role in that part was to administer the sedation under the guidance of a pediatric consultant, and the orthopedic team would come and do any sort of manipulation that needed to be done. We didn't do intranasal fentanyl or nitrous oxide sedations. They weren't agreed in our trust for ED. So I came with a little bit of trepidation to the Alex when it was intranasal fentanyl and nitrous oxide. Is this going to be, is this beneficial? What are the patient experience? Are they having too much pain with this? Obviously, they've got a well bedded in team who know the patients that are right for this. The nurse practitioner team, EMP team, have been doing this for a good few years now. They successfully reduce quite a lot of the fractures we have. We'll come to it in a moment, a little image of ones that we're allowed to manipulate in the ED ourselves, or ones that have to go to the orthopedic team to be reviewed and maybe manipulate. Obviously, it's thinking about, in the children that we do, we had 2 children yesterday that had wonky arms. One in the morning, which was a 4 and 5-year-old. She was obviously too young to think, she wouldn't be able to take she wouldn't be able to take the Entonox with the way that she had been in the rest of the department. Prior to having her fracture identified and managed. So she's obviously come back today for theatre. Then obviously in the evening we had an older teenager who was happy to have the fentanyl and nitrous oxide, and we had a good reduction. Just gonna the other things obviously think if they need to be done in theatre, is there going to need to be some form of fixation? So obviously, if you're unsure before any manipulation you're going to do, also have a chat with your local orthopedic team. Don't go ahead and do something that you're not too sure about. I'm sure most of you all got guidelines in place about what to do.
I just wonder if anyone has any questions at this point, Liam.
Yeah.
Does anyone want to ask anything at this early stage?
Yeah.
I just wondered myself, actually, you said you use ketamine at a different trust. Were you able to treat younger children
Yeah.
Perhaps those that couldn't tolerate the use of the Entonox mouthpiece. You know, so was that better in that regard?
Yes, it was. We could do a lot more with younger children. So we managed to get through that. And I think there was the advantage, there was a major trauma centre as well. We had a bit more levels of staffing. We had 24-hour paediatric anaesthetists. So we were in a good place to be doing this.
Yeah.
It was quite well embedded in. And because we were a children's ED within a large ED, we also have kind of you can have a flow of staff if you need to. So if like there was a little bit of give on the adult side, if you're a bit short staffed on the pediatric side, you might be able to get an adult nurse to come over and give you a hand and
Yeah.
be the extra person. Whereas for us, we have our set staff during the day. If we lose any of those staff, it's a bit difficult because we can't pull from the adult ED because they're in a separate building from us. So that makes it a little bit difficult for us to do sedation. I mean, there is a policy where we are about sedation, but I think, you know, hopefully as we get more staff, we might be able to revisit it. But at this moment in time, it's not something we can do quite now, and I'm sure that's probably the same in some places, looking at those Slidos earlier on.
Yeah, I guess there's a lot to be said for using one strategy that everybody's familiar with. There's lots of safety benefits of that.
Yeah.
There's a couple of questions in the chat actually. Now may or may not be the right time to answer them, but in distal radius green stick fractures, does it matter on the degree of angulation? And would you ever back slab rather than splint? I
tend to think we're going, again, I have a discussion sometimes with the orthopedics about these ones. If I'm going anything, if it's going beyond 15 degrees of angulation, I might have a chat with them to see if they're happy for a back slab or a respirator before going home. Because sometimes if they're very angulated, they might even want to come back and just do a little tweak just to get the bone into a bit better alignment. But obviously we're going to touch on the craft study a little bit later on about which is looking at the remodeling of children's bones if they're left just to heal by themselves for some of these fractures. So that may be something we can touch on a little bit later.
Okay, why don't you go ahead? Thank you.
Yeah. So this is our little, this is on our, and it's not the best image because we had to screenshot it off our guideline at work. But this is our little green light for ones we're allowed to manipulate as nurse practitioners within the ED. It says under sedation, but obviously we're using kind of, we're not using the ketamine or the nitrous oxide, but nitrous oxide 70%, but we're able to do these with the ketamine and sort of the intranasal fentanyl and Entonox. Obviously, there's the ones there that we just don't even bother trying to do it. Let the orthopedic team come down, have a look at them, see if they maybe need to go to theatre. So there, so we've got this little thing, so we can always refer to this.
We do find that sometimes when the orthopedics come down, they try to do things that aren't on the guidelines, and they're like, "Oh, we're just going to go and give it a little tweak," but we have that quite a lot.
Yeah, I mean, unfortunately, I think probably the same as most places, unless we've got the paediatric orthopedic registrars involved, or those that have a keen interest in paediatrics. Sometimes they forget that they're different from adults and what they can tolerate. So we sometimes have to do that subtle reminder. But I think that, again, that's probably something that happens everywhere. So it's, again, about being a good advocate for your patient as well. Yeah, we haven't had too much problems since I've been there. I think I maybe had a few more issues at my last trust, but I won't touch on that. Right. So ideally, this is an ideal world of the key people you'd have in doing these. Okay, obviously you have your parent or guardian with the child. Wanting them to know what we're going to do. You want one person who's able to do the manipulation. One person to do the counter-traction, obviously a person that can administer the intranasal fentanyl and then guide the patient for Entonox. Sometimes, obviously depending on staff, it may be that the person who's doing you've given the person who's doing the counter-action give the internal ventral beforehand, because you're going to give it about 5 minutes before you have time to sort of start working, before you start manipulating, and they can be at the heading, sort of guiding the patient with the Entonox. And again, in the luxury, we have another person who can apply the plaster. So we tend to have, if we're going to manipulate, we'll pop it into a actual full cast rather than a back slab. Obviously, you want the stability. Obviously, we do some good molding towards the end to make sure that once we've reduced it, that it stays reduced. I think Hannah will go through the technique shortly. Obviously, again, if in this world you want the play specialist available, if you've got one, it'd be really good. Or you can use some distraction, mobile phones, music, whatever the kid usually likes, telling some jokes. Or like we're lucky enough to have a good charity called Rocking Horse that have provided us with a 3D TV and some VR goggles. Obviously, we've got lots of pictures on the wall for the kids to have a little look at as well. But yeah, it's working really, really well. A lot of the children aren't really noticing. So I'm going to just hand over to Hannah.
Thanks, Liam. Yeah, so once they've had really good pain relief, we get them going on the Entonox. We try and get them to have 10 really good breaths of the Entonox so they get used to it beforehand. Then usually there is only 2 of us that are doing it, because we don't ever have enough staff for them all to be in the room. We try and do a bit of hanging or horizontal traction. Sometimes you'll find that the fracture straightens out quite a lot with just the traction, one at the elbow and one holding the fingers. We did talk once about getting finger traps to hang the arm for a little while, but the finger traps apparently aren't paediatric sizes and they're expensive. Obviously, we look at our guidelines, make sure they're within the appropriate fracture guidelines. After the traction, we apply the plaster, and then someone will mould it and give it a little bit of an extra support. Once that's done, we re-X-ray to check the position of the fracture. If we're a bit borderline whether the position's gone back, then we speak to the orthopaedic team to check they're okay with it, and then we follow it up with a virtual fracture clinic.
We tend to find that, and I've seen it, that a lot of patients do manage this very, very well. And a lot of the literature you'll probably read around these techniques, with the intracemental and lateral side, there's lots of parental satisfaction. I think one of the issues that maybe does need to a bit more literature, I can't really find too much on it, is we don't necessarily always check on the people who are actually having it done. So we don't necessarily get always, a lot of the satisfaction thing, there's not much given back, identifying what the children are thinking about these techniques we do. I mean, a lot of it is anecdotal. We see, these kids seem to be quite happy with it. Maybe we should be having a look at, is there some way that they can feedback, if there's anything different that they might want to suggest, or, if those children that might be a little bit shy and try to pretend they're not being in discomfort, maybe they want to feed back to us. I mean, we try to give them, we also give them the option to say, raise your hand if it's feeling too uncomfortable. We always say there's going to be probably a little bit of pain. We say we can't take everything away, and they're going to have some feeling about what we're doing. And obviously, we would never want to push a child beyond what they're able to manage. Because we can always, refer to your orthopedic team, and if it comes that they have to go to fit to have this done, then so be it. So it may be something in the future we maybe as a research idea, if anyone's looking for one. I don't have the time to do it myself right now. Is whether we need to look at what sort of experience the children are having when they're having these techniques done. Just before we finish the slides and go into some questions, there are some standards out there. So you've got the there's a British Orthopaedic Association have the early management of pediatric forearm fracture ones. So there's a good little guideline about standards of what they expect in a department. We've been having a look at this, and whilst we meet the majority of it, I think we probably need to maybe look at producing a little pro forma for when we actually do these procedures, so we can actually audit that we're actually meeting all these and ourselves. And then there is the craft study. Let's see if it's a little study, well, not a little study, it's quite a big study, looking at whether, you know, some children can their fractures, do we need to be doing anything to them? You know, some of these sort of children that have quite a bit of bend in their fractures, could they just be left in a plaster cast? Will it remodel naturally? So just trying to get people into it, and they're trying to make sure it's 50-50 on each side, so they can compare. Because we got a good little book in our office that shows sort of bone modelling for children over time. So we use that to sort of show parents what we expect to happen to the bones over the next few months or year, to give them an idea of what to expect.
The parents really love the book and looking at the fractures and how they heal on their own without any surgical intervention. It's a really good book to take with them to see. Thanks, Paul.
Yeah, we had a little child. We had a child in yesterday that had, the parents came in. He'd had an MUA done with some fixation about 7 weeks ago. He's come out of his cast a couple of days ago, and Dad had noticed a lump in his forearm. Wasn't sure what it was. Obviously, it's the healing callus, and we were able to show him on the, in the image, obviously on his own image anyway, using the evidence from the book. This is what's quite normal for this stage, so they were quite happy and reassured. So that was quite good. Obviously, we can have some questions now, and maybe if people want to have a little discussion about stuff. And if anything comes to mind after this session, then we've left our email addresses on there that you can obviously drop us an email. If you want to add something to us and say, like, we've got this idea, this might be helpful to you, or if you just want more information about what we do, then that's absolutely fine.